Okay, let's go ahead and pick up where we left off yesterday with complex regional pain syndrome. So we have two types, as I alluded to in the quiz. The first type used to be called reflex sympathetic dystrophy, and that kind of talks about the cause and what's going on with the pathophysiology. So that's a cyclic, inflammatory response that follows the fight or flight response. So the body is telling the brain that something is wrong, and the brain is actually confirming that, and that creates a cycle in which the patient really can't break out of. It's not the fault of the patient. It is just like a feedback signal with if you stand too close to a speaker. So that's kind of what's going on with a type 1. Some other terms that they use for this would be an algodystrophy. Sorry, I put extra letters in there. Algodystrophy, which is that description of a nerve pain. So like a burning, searing type pain. So those are all phrases that we would use kind of pointing us down towards type 1. That's not to say that type 2 doesn't have that burning, searing pain, because it does. It used to be a phrase that was synonymous with complex regional pain syndrome. So type 2 CRPS is something where there's actually something wrong with the nerve. So we can measure it either with imaging, or we can see that there is something wrong through a nerve conduction study or something along those lines. So 2 divisions. So what do we find in these folks? Burning, tearing, searing, or throbbing pains are most common. And they kind of have this is like a complex regional pain syndrome handouts briefings. So they have some pretty typical additional side effects that could be impacting their daily living. And so this is a good way to kind of remove those. Give me 1 second. The baby monitor is going off and I don't want it to distract you guys. Nothing worse than listening to my baby monitor say it doesn't have a signal for 2 hours. Okay. So let's talk about some additional things that we'll notice. So in the world of orthopedics, you'll hear me say the phrase red hot and swollen a lot. But there is a difference with this in terms of the distribution. So a red hot swollen joint, we'll talk about that later today when we get to septic arthritis. But this will additionally be very sensitive to touch, extremely so, and it's an appendage, like the whole thing. So that could be a differentiator in terms of testing material, a joint versus an entire leg or arm. Still didn't fix that baby monitor thing. Hi, super fun. Okay, and an appendage instead of a single joint. So what do we do about complex regional pain syndrome? So first, orosympatholytics. So this has to do with that signal breaking. So those sympatholytics, such as gabapentin or pregabalin, that's the break in that cycle between the injured part and the brain coming round and round. And it basically says, hold up, that's just noise. Stop treating it as a pathology and stop trying to recruit, the healing cytokines and all that. Let's take a knee, let the body get caught up, and then we can reset the system and look for that signal again. Some physical therapy might also be a good idea if they have atrophy or changes in that limb as a result of the complex regional pain syndrome. They can also do some desensitization as part of physical therapy. There's like some mirror therapies where they look at that body part and say, hey, it's okay. You're just touching lightly. It shouldn't cause pain. And they can work with the patient on that. Now, it also does say psych. Now, I'm not saying these people are crazy. That's not what I'm saying. I'm just saying that if nobody can touch my leg, clothing hurts, it hurts to lay in bed, that's going to be a huge disruption in my life. So we're not saying this is crazy people. We're saying that these people have something going on and it's majorly affecting their life. So we don't want to ignore that and treat them just as a limb. We want to make sure that we're giving them the support that they need. And then operative treatment is rarely, very rarely, and only for that type 2. There is no operative indication whatsoever for a type 1. You have to have something that you can put your finger on, that you can remove or fix something operatively. Let me get caught up on the chat. Pistoia, are you talking about like this, the physical exam, or kind of what aspects? Oh, starting the medication. Yeah, got it. Okay. No, you should be able to start the medication in both types to see if we can get that signal to stop. So it would apply to both types. And it's not necessarily the spine, Jacobs. It's higher than that, higher order. It's brain, cranium stuff. And it's basically interpreting. It's very similar to a feedback loop. So the signal's there. It's just the body is making it more than it is actually worth. Wilson is asking oral meds only for type 2. So no, both types to start. And only if those failed will we get to this operative. Let's see here, Anders. So Anders is trying to differentiate between like kind of what's going on in 1 versus 2. And they're very similar in terms of the signal to the brain. It just happens to be that with type 2, there's actually something wrong, something that we can say is wrong, whereas with type 1, we might not be able to find that with imaging. In type 2, there is damage, Jacobs. No, Jacobs, in type 1, no damage. It's all about signal. It's not bad music. It's just you're standing too close to the speaker. Okay, while he's finishing up typing, so the great thing about this particular problem is we do have an additional consult service that can help us with that, and that's the pain specialist. So this is polymodal usually, so they'll address like injectable, intrathecal, oral medications, physical therapy, psych. This is the person who pulls that all together and brings, addresses this patient's lifetime pain. So that pain management might be another way you've heard that before. Something along those lines, yes. And Morgan, early is great. As soon as you recognize that it's CRPS, you should get them in with pain management. Okay, let me switch over to the next presentation. Okay, confirmation. Oh, I forgot to give you your brief back on yesterday's thing, so I'll do that right now. So yesterday we had a question that I couldn't answer about the seronegative spondyloarthropathies and lab values. And the bullet said negative RF and anti-CCP. And the question was, so should anti-CCP be negative as well? And that is a true statement. So the text only goes into rheumatoid factor and ANA, anti-nuclear antibodies. But I did look up anti-CCP because that's what I chose to put on the slide, and it is also negative. So all three of those should be negative in a seronegative spondyloarthropathy. Those were rheumatoid factor, anti-CCP, and ANA. Okay, let's dive into lecture 2. So we got a lot to cover. We still have time to do it though. So crystalline deposition disease, DVTs, DISH, fibromyalgia, osteomyelitis, and septic arthritis, Lyme disease, osteoporosis, overuse injuries, sprains and strains, and tumors of the bone. And I'm going to kind of go fast and slow depending on how critical these things are in terms of differentiation. Let's go ahead and start with the crystalline deposition diseases. So there are two of them. One is gout and the other is pseudo-gout. So gout is caused by an increase in uric acid in the blood. And that can be, just like you guys learned in pathology, overproducers or under-excretors. And the body basically tries to sequester out that uric acid by putting it in predictable joints. And I'll talk about where here in a minute. Pseudo-gout, on the other hand, is a calcium pyrophosphate deposition problem, or CPPD is the abbreviation there. So gout, I've kind of picked joints that were applicable. So let's talk about where those are. So with this, they are going to have episodic, severe, it's excruciating for these patients, red hot swollen joints. So the differentiator here is going to be an infection, because this will mimic a lot of things that we have with, yes, folks, it's all that red meat, will be our differentiator. So the episodic might be different. So kind of look for that particular word when differentiating these two pathologies. Joint can also help us in figuring out what it is. So gout usually presents in the first metatarsal phalangeal joint. A couple other common, the knee or the ankle are common joints for gout. Pseudo-gout, first most common is the knee. Other common places are the wrist. It's not saying it doesn't happen in other joints. They just happen to be better places for the body to filter out this, the crystals. Hold on. I really like being able to talk. And then our adverse outcomes of the disease has to do with the kidney trying to filter out the crystals. So it's kidney disease and damage to the kidneys. Let me go ahead and switch back over. Captain Graham's talking about all the good things in life. And then, yes, crystals, lots of crystals. Joints just have vacancy signs up. It's more like the body's convinced that it's a great place to store stuff, but it's really not. And yes, Fuchs, I support those, that medicine choice. So we'll get there in just one moment. And not particularly why it picks those joints above any other joints. And colchicine works. It's just a little older. It's old school. Okay, physical exam. So one of the things that we can find is tophi, and kind of addressing Jacob's question. It's not just joints. So tophi can occur, they're uric acid depositions. They can occur in weird places. So the cartilage of the ears is one location. Here's some tophi in the fingers. There's a physical exam of that first metatarsal phalangeal joint. That's Kimes' answer, metatarsal phalangeal. Looking at that, and then kind of the tophi here, looking a little less irritated. So what's the thing that you will need to commit to memory for these two pathologies? It should be the same as it was for pathology. So you need to know which crystals go with which. So for gout, if I look at that joint fluid, I'm going to see negatively birefringent crystals. That has to do with the light that we apply with the microscope. And they look like this. They're very pretty. And then additional things that we could look at are the serum uric acid. This tends to be less predictive. So if a person is even having an active gout attack, doesn't necessarily mean that they'll have an elevated uric acid, but we could do a longer term uric acid evaluation and make sure, look at that. And then in terms of looking at their x-rays, there are some pretty characteristic x-ray findings for gout as well. So this is subchondral erosions. So previously we had pathology that had subchondral cysts. That was osteoarthritis. This is going to be an erosion. So you'll be able to have just deep to the cartilage layer starting to wash away that bone of the distal portion. And they may form some bone spurs more away from the joint, not necessarily proximal, just not at the joint like they would with an osteoarthritis. So kind of watch that. Erosions word is going to be your difference here. With pseudo-gout, on the other hand, when we look at the microscopy, we're going to have positively birefringent, and they're going to be rhomboid shaped, so squares and hexagons and all those weird shapes. So looking here at that pink one, you can see the shaped things, much more shapely. In x-rays, they're going to have chondrocalcinosis, and that means that we can start to see, because of calcification, the cartilage surfaces. So normally, like we talked about yesterday, we shouldn't be able to see the cartilage on an x-ray. But for these folks, they start to turn that cartilage into bone. So we will be able to see that on x-ray, which is not normal. So what do we do about it? We've kind of already talked about it in the chat. So we do have colchicine and indomethacin as our two primary anti-inflammatory type medications. So they both address that aspect. And then allopurinol kind of changes how we're looking at the balance. So all of those three are options for treatment based on whether we complete the workout and they're under excretors or overproducers. So Anders, just watch if they're under excretors versus overproducers. But yes, generally allopurinol is our longer watching medicine. So kind of to address Jacobs and Scott's question, both. So we're trying to get those crystals from, they're very irritating, very much like sand in the joint. So we're trying to both quit the body from depositing them and stop the body from being pissed off that it did deposit them. So they work through that mechanism. That's why they're older medicines. Day Sands, I use indomethacin in acute. So there's overlap, Huang, between in the class. So indomethacin is a non-steroidal anti-inflammatory, so you can't give them both at the same time unless you are terribly short on options. I don't need to give them a heart attack by itself. Two people are typing, so I'll let them finish up before we move on to DVT. Jacobs, I would say just not both. So I use indomethacin almost exclusively in gout. I have used other things, and I have used indomethacin outside of gout, but it's really paired with gout. There are other classes that do other things better for NSAIDs, but indomethacin is our gout friend. Okay, let's go ahead. Matthews is still typing. If I have to come back, I will. Deep vein thrombosis. So I let Colonel Jones do most of this, but let's just go ahead and review some key points on deep vein thrombosis because it does occur in an extremity. So remember, our Virchow's triad is our risk for formation of a DVT. So what is that triad? Venous stasis, holding still for long periods of time, intimal damage or something wrong with the inside of the blood vessel, and then some kind of hypocoagulable state. So in orthopedics, it's usually some kind of surgically induced stasis. They break something and we have to hold it still in a cast, or we do surgery and they can't move around because we did surgery on it. So stasis is really where this becomes an orthopedics problem. There are plenty of other reasons to get a DVT. Ortho just does hold still really well. So in terms of the DVT itself, severe leg pain is going to be our major criteria for looking for the DVT. Just know that the leg is the most common, but there are upper extremity DVTs that would apply to stasis within that limb. So holding still for like an arm fracture. And the scary thing that we care about that happens from DVTs is that blood clot breaks off and floats up into the lungs and gets lodged there, adversely affecting our oxygen exchange. So really watch that. That's the whole reason we do everything that we do for DVTs. So in terms of orthopedics, what do we test for with this? It's Homan's test. So it's passive. I had to remember what I haven't taught you yet. Dorsiflexion of the ankle. So bringing the toes to the nose, and they're going to get pain, excruciating pain in their leg as you kind of push that venous flow up against that blockage. So it's going to cause them some pretty excruciating pain because there's just nowhere to put the blood. Holman's test. So some imaging that we can do to look at that. So venography is one. So we put a contrast agent and then we run a CT. That's kind of what we do these days, though there are some other studies that we can do. So here's a contrasted CT showing that blockage where the double arrowhead is, showing that blood is not getting where it's supposed to be. In terms of screening for a DVT, we can do that with an ultrasound. So that can go either way. Most people have some kind of blood clot in their extremities, especially as they age. So there's some false positive rates there, but it's a great way to go fishing without endangering the patient with ionizing radiation. So we can go and they look at the vessel, find the right kind of vessel and smash on it, and they can see if that vessel changes. EKG, total. You guys have had Dr. Mashad, so I'll let them, because they're way better at that. Chest x-ray, maybe you can find some signs, Westermarks, those types of signs of DVT on a chest x-ray, also not high confidence level. VQ scan is also kind of an older way of looking at that. That's that ventilation perfusion, V and Q, ventilation and perfusion. So we look and see, here's that depiction. We show where air goes in the lungs. So make sure we can measure what is lung in this human being. And then we look at the blood that is going to that lung, and they should match. The pictures should be the same. So anytime those two pictures differ, we would say that there's a ventilation perfusion difference. Yes. Okay, Venus or Serena. We could play tennis. That's true. Holman's test, increase the risk of breaking the clot off. That's a great question. And I would imagine so, because any calf motion risks that. Would you not do the test because of that risk? I would say do the test because we can get treatment for them then rather than not. Those are great questions, Morgan. So with the ventilation perfusion scan, those are all looking for the complication, the PE. Really, I didn't know that, Fuchs. Thank you for that little bit of tennis history. I didn't know. I would not wait. If they had pain and with a Homan's test, I think I'd just start treatment. I think I would probably start treatment if I had a high enough clinical suspicion either way. So let's talk about what that is. So first thing in the orthopedics world is prevention, prevention, prevention. So if we're going to immobilize something or do surgery on a body part, we treat with prevention first. So our first line drug for that is going to be enoxaparin or Lovenox, injectable. We teach the patients how to give it to themselves at home, and we discharge them with that medication. If there are contraindications for that, our second choice would be warfarin, and our third choice would be increased aspirin. There are protocols now that are going back from that and favoring aspirin because of its lower side effect profile. So just stay tuned, because it'll change in your medical career what we do. And then, yes, I'll talk about that in a moment, Matthew. So the last one is mechanical prophylaxis. So that's what's indicated here in the bottom. So these are sequential compression devices. We put them on patients that are in the hospital, stuck in their bed, and they take them off all the time. And then the bed yells at you, or the device, depending on what it's attached to. But yes, they hate these things. I have a story that I tell about rounding during residency. We went in and the patient didn't have his compression devices on. The resident went through and put them back on. And I still had something that I had to do. And the resident walked out the door, and the guy literally took them off like as soon as he was out the door. And I was like, no, like seriously, you really should keep these on, or get up and go to the bathroom so we can take your catheter out, which is, pick one. I don't care. But quite literally, the second the doctor walked out of the door, they took them off. It was a little bit of rebellion I saw in that patient. Operative interventions involve going in and taking that blood clot out. They don't hate. Yeah, but they do hate warfarin more. I said that's true. And yes, Jacobs, those first through third are all prevention. Treatment's a little different, depends on how bad the clot is. I want you to focus on prevention. Clot busters are cardiac. You don't want me talking about those. The more proximal the DVT, the more likely it is to break off. So if you do your screening ultrasound and they report something more proximal, it's worth getting them referred. Remember, that's a vascular thing, not necessarily an orthopedic thing. So please get them to the right consult. I can't fix their DVT. It's usually proximal to the popliteal fossa. So more from behind the knee towards the core. Okay, let's talk about DISH, and then we'll go on our break. So DISH is diffuse idiopathic skeletal hyperostosis. There's that landline again. You guys are going to be so excited by my landline. So all over the body, unique to the patient, bony, making extra bone. So just breaking that name down, it's they make bone spurts, and they make them more likely around their pelvis and spine. Thanks, Major Moore. So again, excessive bone formation around the spine and hips, and we'll kind of look at what that looks like. That bone formation creates a decreased range of motion, most notable within the spine. So you'll find that same decrease in range of motion that we talked about with ankylosing spondylitis. We'll find that here in DISH as well. So this imaging slide is really to help us differentiate between this and that ankylosing spondylitis. So we're going to see a lot of similarities here. So the thing that we're looking at here is a spine lateral, and we're going to see anterior fusion of 4 contiguous vertebrae, so meaning in a row, with that same intact disc height. So remember, that is the same as ankylosing spondylitis. So the thing that matters here is that it's anterior, whereas ankylosing spondylitis was all the way around the disc space. So this is actually fusion of the anterior longitudinal ligament. Woo! So all the way along the front. So looking at our x-ray here, zooming in, switching to hand. So yesterday when we talked about ankylosing spondylitis, we had that same bowing that looked like this, but here at the back. Here we've got like a completely normal posterior section, but we've got this great bone spur anteriorly. So 4 of those in a row make dish. This can happen anywhere in the body, anywhere. This is pretty good, Morgan, in terms of disc height. It does look like this one's a little low, but they should have a disc. So looking at that, and then this can be anywhere in the spine was where I was going with that. So when we talked about ankylosing spondylitis, it had to be from the bottom and it had to work its way north. This could start in the thoracic spine and go out, could start in the cervical spine and go out. So that's the difference, is that ankylosing starts at the SI joint and works its way up the spine. This can start in the middle and go either way. Kind of a way that it'll get confusing in terms of mean things that the body does to confuse PA students. In the C spine, that posterior longitudinal ligament may also calcify. So that would give us that bony bridge along the back as well. But what we would see that would differentiate that is a normal segment below that fusion. So they may have fusion both in the front and the back and the C spine, but underneath that, they're going to have normal levels where there's no fusion. And that'll be our indication for dish over ankylosing spondylitis. Earwood, I think it's everything. They can't rotate, they can't forward flex, and they can't extend. These folks will break, kind of as somebody was bringing that up. They can fracture because it's not all the way around. Dish folks can fracture a little easier, and they'll just crack that spot at the anterior longitudinal ligament. I'll talk while you guys type. Things that we can do about it. So this is all about keeping them active for as long as possible. So we want to keep them moving. We don't want to shut down any activities that they enjoy doing, and anti-inflammatories as needed. Biggest limitation really for the patient is not pain. It is limitation in range of motion. It's uncomfortable. Don't get me wrong, but they're not usually there for pain meds. Yes, Jacobs. We treat it like a normal fracture because that's what the body's saying, and it will actually keep making more bone. So it just treats it like a fracture and lays down extra. A couple people are typing. Usually they'll give them like a home exercise program bigger so that they don't have to take up the assets that come with physical therapy for long periods of time. But again, it's not necessarily pain. It's usually lack of motion. And yes, Jacobs, we still immobilize them. We put them in a spine brace so that it regrows incorrectly. It's exactly right. Kylie's asking lordosis. It's definitely going to freeze. However, that bone spur catches it at. So if they had some disc degeneration, acute disc degeneration, it'll freeze like that. Kind of like we saw in that patient that was in the x-ray. That's a great question. Would it make them more at risk for a posterior disc bulge? It doesn't bend much. It doesn't flex at that bone. I think it would just break, but that may change the force enough to cause a posterior disc bulge. It's a great intellectual question you asked me there. Okay, I said we would stop after that for our break, so I will go ahead and start your 10-minute break. I'll see you back at 1 till the hour, so 13:59. Back in with some learning about fibromyalgia. Camera's coming up now. While it is, we'll talk about fibromyalgia. So fibromyalgia is going to be a pattern of generalized body pain, maybe associated with some fatigue. My goodness, dropped too many letters there. And some soft tissue tenderness that has some diagnostic criteria. So diagnostically, they need to have pain in all four quadrants. So here a quadrant is an appendage. So right upper extremity, left upper extremity, right lower extremity, left lower extremity are our four quadrants. It should be episodic and lasting more than 3 months. So that means they don't have to have stuff for 3 months constantly. They can ebb and flow for 3 months to meet diagnostic criteria. And when we do their physical exam, we will measure their tenderness at each of 18 points and record that as part of our note to support our diagnosis of using the phrase fibromyalgia. So we'll, very similar to this map, note that they're all different quadrants, and we'll push on each of these and record which one has tenderness or no tenderness. And that becomes supportive of our diagnostic criteria. In order to treat fibromyalgia, we really have to open our thought processes and use holistic medicine. So pregabalin, duloxetine, and malnacipran, have all been FDA approved to treat fibromyalgia, but that's not the only medicines that we can use. So we kind of know about pregabalin in terms of stopping that feedback signal to the brain. Duloxetine is an antidepressant that has coverage here. And honestly, I don't use malnacipran very often, which is why I can't pronounce it. So if I needed an additional modality, then I might extend into that. We may use oral anti-inflammatories, topical anti-inflammatories to treat that, depending on their GI and cardiac risk. And then amitriptyline, another antidepressant. Not to say that they're necessarily linked. We just have found that there is crossover with amitriptyline in being able to address the other musculoskeletal symptoms of fibromyalgia. And I'll come back and talk about kind of some other aspects of that here in a minute. Dry and wet needling, so really incorporating Eastern medicine may be helpful as well. And the big thing is that it's polymodal. So we may be throwing every aspect of our both Western and Eastern medicine in trying to get this patient to be better. Physical therapy, behavioral health. And again, it's not saying they're crazy. That's not what I'm saying. I'm just saying that if all four of my appendages hurt at the same time and I couldn't get up because I had fatigue, this is life-affecting stuff, not synonymous with crazy. So we have to treat them as a being and not as an appendage or multiple appendages. We need to help them, make sure we support them through the impact that it has on their life. So polymodal pain management can also be another key player in this. So consider that kind of in your development of how you're going to treat. These usually get whole teams worth of people. So we get case management involved and we manage them as a polymodal patient so that we make sure we address the whole being instead of just one ache or pain at a time, which would get very repetitive and boring and not useful. Fuchs is typing, so I will pause. Oh, multiple people are typing. I'm going to go on, gentlemen. I'll come back if I need. No, see, I say that and then it pops up. And yes, so that's kind of inappropriate prescription of opioids is kind of a complication with fibromyalgia because this is pain that they have. It's not made up in their brain. So kind of looking at other solutions is why we have the polymodal aspect of it, because we want to avoid opioid addiction and other patient harm issues. Yes, that is true, Jacobs. So even in my practice, dry needling comes into play fairly often. And I'm battlefield acupuncture certified. So we use a lot of modalities to get people through musculoskeletal pain. And no, I wouldn't say horse pull. It really is psych over physical stuff. We try to keep it equal. Jacobs, I would say that more people are becoming BFA certified. So we had training here at the schoolhouse, but I did it to support one of my residents who was doing a study on using that to kind of distract from the discomfort of a couple of the knee injections that we give that we can't temper with the numbing medicines because it would contradict what we're trying to do. Like the PRP hurts a lot. So if we do BFA at the same time, we can create the same inflammatory response in the body without making the patient incapable of doing their Army or Air Force job. So I say more common now. Okay, let's go on and talk about osteomyelitis. So this is a bone infection. So when we talk about this in terms of right now, we're going to hit mostly the adults, but we'll come back to it again for the pediatric section tomorrow. So adults, most common way to get this is direct spread. So that something punctures through the skin and puts those bacteria in the bone. Most common bacteria to set up shop, Staph aureus and Pseudomonas. So both skin bacteria. Pseudomonas happens more in the foot. That's why it's this lovely green color. Love the picture for this one. Because that's common in feet, but other places maybe Staph aureus due to just that's what's on our skin. And then pediatrics, it is more commonly hematogenous spread. So the bone filters out that bacteria and the bacteria likes where it stopped off and decides to set up home there. Some common pathogens there, Staph aureus and group A beta hemolytic strep. So those are both skin bacteria. Haemophilus influenza used to top the list, but now that we have vaccines, that is crashing down. So it might be something we see more in our deployed environment. So that's why it's on this slide. Not common here where people are vaccinated, but if you have an unvaccinated child from either because of their country of origin or parental choices, they may have that as an option as well. Anders Pseudomonas is the one we expect in diabetics. And ew, gross. I can smell it from here. Smell-o-vision. So what would we expect these folks to have in terms of complaints? Fever and a deep pain history. Fever and deep pain. And then history is going to be our big clue. So did they stab themselves in the foot or the knee or wherever they have the problem? 2 vocab words I need to introduce you to, sequestrum and involucrum. So sequestrum means that the body has sequestered it off. So the body is trying to isolate that infectious process, kind of depicted here on this far right. I can't zoom right now because my computer is trying to tell me I have emails. So we can see here the body has tried to wall off that infectious process. So we call that the sequestrum. And then our involucrum is the bone growing underneath the periosteum, even though it's elevated because of the space occupying infection. So those are two vocab words that come up with osteomyelitis. So things we can do to look at it to further evaluate. MRI is necessary. Used to be we could also use a bone scan. Bone scan was mostly to help us differentiate between those diabetic feet that Anders brought up for Charcot feet, which we won't talk about until block 4. And kind of looking at the difference between Charcot and osteomyelitis. But the MRI will also tell the difference. Only way to be sure is to go in and take a sample of that bone and make sure that there are bacteria living on it. So we'll do that biopsy as we do their surgery. Some additional labs we need to follow these patients: white blood cell count, and then erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. These two together are going to be called inflammatory markers. And when we talk about that, all I'm looking is non-specific, very, very non-specific labs there. They are just going to tell me that something's wrong in the body. Can't tell me what. Can't tell me infectious versus inflammatory for like an RA. Just telling me something's wrong. So whenever I throw out the phrase inflammatory markers, I'm talking about ESR and CRP, and we just track those to make sure the patient is getting better. Jacobs is asking, what's that sequestrum membrane made out of? Biofilm. It's the same basic construct as a cystic structure or a granuloma in the lungs. It's gross. Ew. Okay, so what do we do about it? We handle osteomyelitis by debriding the bad bone. Sorry, he's asking follow-up question. Produced by the bugs or the body? Both. So it's the interaction between the two that makes the wall. The body makes bad stuff. Sorry, bugs make bad stuff. Body says this is bad stuff, and they push up against each other. And they form a line. We have to get rid of the disgusting bone. So we do that by surgical debridement. So we go in and we actually remove that bone. And that plays back into where we talked yesterday about amputation levels. So this person just happened to have lots of stuff taken out of the lateral part of their foot. But if necessary, we would have to amputate or take a ray resection or something along those lines to get it so the bone that was infected was gone. Let's go on to septic arthritis. We'll carry on the thought of infected things, but now we're going to make it a joint that's infected. So in adults, this can be either direct or hematogenously spread. So from a direct seed or from the blood filtering out that bacteria and depositing it in the joint, kind of along the same mental process of that gout crystal. This can be an extension of osteomyelitis. So if they have osteomyelitis within a bone adjacent to a joint, we will usually assess the joint fluid to make sure that they do not have that spread into the near joint. And again, most common bacteria is Staph aureus skin bacteria. Pediatrics, again, most common way that they get this is hematogenous spread. So the body filters out that bacteria and deposits it in the joint. So what do we see on exam? This is that red hot swollen joint as opposed to appendage that we talked about earlier. So tenderness, effusion, and erythema around that joint. So see how they have nice normal skin here proximally and distally, but this joint, this knee joint, is angry. That is going to be related to poor range of motion and weight bearing. So if we're talking about a leg, that would be walking around. But if it's an upper extremity, any kind of bearing through that joint, I call it axial loading, that will also be limited in that patient. So a patient with something that's adjacent, like a cellulitis or an osteomyelitis, will probably still be able to do some range of motion. It might be uncomfortable, but they won't be trying to, punch us and cling to the chandelier and whatnot. But these folks, any type of loading of that joint will be excessively painful. So that's kind of an absolute. They will do none of this for no reason, no range of motion. They will hate you for it. So we will get some labs to check that on that. So we're going to look at their blood, and we're going to get white blood cells and those inflammatory markers that we'll track and see to make sure that they're getting better. But we'll also look at the joint fluid specifically, and we'll look at for some of those same things. White blood cell count, that would make sense. How much is the body depositing white blood cells in to fight that? But we'll also look for some other characteristics to rule out some other things that we've talked about, like gout. Remember, I said the differential for those are really close. So I need that crystal assessment right away. And then we'll wait on the gram stain and culture to really look at if it grows anything that would be bacterial. Cell count is the laboratory for looking at it under microscopy and looking for those white blood cells or those crystals. They can count how many red blood cells, because I did just stab them in the knee with a needle. White blood cells, red blood cells, crystals. They'll look at it and they'll give us a count of those things. Cultures, yep, grow stuff out. I assume, folks, that you meant like with the serum. And yes, we do that as well. I had to turn it to you for a second. Why you would ask that question. So yes, we are running very similar tests on the blood and on the joint fluid. I think I don't have cultures here because that's not necessarily expected in an adult. It would be in a kid, but not necessarily in an adult. So what do? This is a very important order, and Peds and I have worked very hard to make this consistent between ortho and Peds. So the first thing you need is a sample. So in this case, it's an aspirate. Second, you can start your antibiotics while you have your aspirate doing crazy things. And then they need to get to the OR. So that is an order, and the order is important. If you cannot aspirate because of something that's outside of your control, the lab is, I don't know, something bad is happening in the lab that inhibits all laboratory analysis and sample collection, then you should go ahead and start treatment. But barring craziness, weird scenarios, you need a sample before you start with IV antibiotics. And then they'll go to surgery, and that's disgusting. That's pus flowing out of a knee port on a patient. And it smells. I can smell it from here. Every patient with septic arthritis needs to come and see ortho so that we can drain that disgusting pus-filled joint. We're going to transition to Lyme disease right after Jacobs finishes typing. Exactly. So we're looking for specificity on our antibiotics. Fungal. I saw fungal septic joint once. It was gross. Took us forever to figure out what was wrong, too. Lyme disease, you're going to get hit on this multiple classes. Hopefully Path already made some dent in that. Get it an infectious disease, too. So when we talk about Lyme disease, we're talking about a spirochete, Borrelia burgdorferi, spread by a tick, Ixodes damini. This is our friend, the deer tick. There are other ticks in the same group. They're just not North American ticks. So they usually, if it has this as its genus, it can be a carrier, just in case you wanted to do a study someplace else, like Afghanistan. So they go in, they latch on, spit in you, gross, you get infection. My favorite part about this sign warning about ticks is this part right here. That sign says that actual size of an immature tick, and there's a little spot on their sign. It's my favorite part. So just for your amusement, when you come back and study these slides, you can be amused at the little dot on the sign. So kind of there's a very typical pattern for them to have symptoms. So first they're going to get viral symptoms, flu-like symptoms is another way of saying that. So they're going to feel like crap. Second set of symptoms are going to be neurologic or cardiac based. So still not orthopedics. After that is when they get the arthritis. So they've usually passed through several phases before they end up with ortho complaints. But they also get some more advanced neuro in that phase as well. Yes, exactly. Ticks in the mirror are smaller than they appear. They're cute. So cute. Some things that can happen as a result of this. So we're here talking about it in ortho class because of arthritis, but some neuro things, facial paralysis, fatigue, concentration defects. We got cardiac complications like cardiac blocks, and then back into neuro for neuritis. Maybe they're dead, Jacobs. I would hope that they are. Or he's got a family of ticks growing on this finger. Our big sign and symptom for this one is this very typical rash that forms around the location. It's erythema migrans as it migrates out, the redness, target lesion. And then again, those constitutional feeling like crap, flu-like symptoms. So those are going to be our initial findings long before they have arthritis. So what do we do about it? This is another one of the topics that prevention is our key. So military-wise, we prevent this by tucking our pants into our boots. Everybody wondered why we did that. Well, that's why. Also comes into our permethrin-soaked uniforms, hopefully not the one you're wearing. We can use bug spray like an off. Check people for ticks. See another smile while you study. Okay, so Brad Paisley, check you for ticks. And then we take them out correctly. So if you pull on their bodies, their heads pop off because they're arthropods and they don't have necks. So make sure you grab their head so that it comes off too. And worst case scenario, Lyme disease is a lifetime disease. We can manage some of it with oral antibiotics. Doesn't make it go away, just makes it stop annoying the patient and I for a while. Okay, next we're going to talk about osteoporosis. More bone stuff for me. So definition of osteoporosis is going to be a decrease in bone mass and some microscopic changes. So normal bone looks more like this upper picture. We can see kind of the structure between each of the sections of the chondrocyte or osteoclasts and blasts. Whereas in osteoporosis, there's an imbalance between the osteoblasts and the osteoclasts, resulting in weak bone. So the osteoclasts are winning. So results in osteoporosis. There are two types. Primary can be divided further into two types. So primary, this is the one we think of when we think of old women. So type 1, that has to do with the hormonal changes as a woman ages, and that results in bone loss. So kind of like I said with the osteoclasts winning. Type 2 has to do with metabolic changes and is their inability for the osteoblasts to not catch up. So they don't have the building blocks needed to make good, strong bone anymore. That's in contrast to secondary, which is Yeah, I hate to say generic. We'll go with men in this one. This is caused by something else. So it could be a metabolic disease, it could be drugs, it could be an endocrine disorder, but it can pull the statistics a little more into the male clause. And you'll talk more about osteoporosis in terms of these two causes in endocrinology. So what do my patients come to me complaining of? Well, I usually find them because they broke something. So first thing I do is I need to get a good history to figure out where I'm going to differentiate them into type 1 or primary versus secondary, type 1 versus type 2. So I can go ahead and get history to look at that. How many fractures have they had? Are they taking any of those drugs that put them at risk? Are we talking about a young person or an old person? So I can start grouping. Adverse effects of this disease, fractures are a big one, can result in deformity and chronic pain. The big ones that you guys are familiar with are hip fracture. I've fallen and I can't get up. But we also have spine and distal radii as our other big fracture patterns for osteoporosis. So one of the measures that we use to look at how bad osteoporosis is a DEXA scan, dual absorbometry. See, that's why I say DEXA, because I can't say the other word. So we run the patient through the machine, looks kind of like this, scans them from head to toe, so we get their entire body, and puts out their relationship in a standard distribution curve. So if I assess the bone density of every woman ever, I would, in theory, get this nice bell-shaped curve, right? Women who have extra dense bone, that's not who we're talking about. So we're never going to be talking about anything from 0 to more dense. So those are all your positive numbers, positive 1, 2, 3. Those people have extra dense bone, positively dense bone. However, anything with a negative number means that they're on this low end of the curve. So they have not negative strong bone. And we have defined kind of what is acceptable based on how many standard deviations they are off from that. So if they are between the 0 and the -1, we say, ooh, that's not great, but it's not terrible. So we're going to watch you. So we're going to say that's acceptable or normal. If they're between -1 and -2.5 standard deviations, we're going to call that osteopenia, or decreased bone mass, but not yet to osteoporosis. And anything more to the negative side than 2.5, we're going to call that osteoporosis. Let's see here. So Scott is asking about osteogenesis imperfecta. That is usually by bone biopsy. So we actually have to look at which cells are rocking the world and their formation, because it's all about the organization at the cellular level. I suppose you could use this. I'll have to think about that. There may be applications. My brain is saying maybe. So what do we do about it? So remember that this is this -2.5 and below. So they've got osteoporosis. I definitely need to treat with calcium and vitamin D. So I've got to give them the building blocks that the osteoblasts need to make bone. We need bone forming cues to the body, impact exercise. So they need to do something with their body. Walking's fine, okay? Because we're talking about old people. I don't need them with a new running regimen where they're trying to be crazy. See osteoarthritis above. We need to avoid the things that may cause this, like alcohol and tobacco. So if they're heavy drinkers or heavy smokers, we need to get them to quit. And we need to decrease their fall risk. So we need to decrease the risk of them falling and breaking their hip or breaking their distal radii. Means like get rid of carpets, decreasing small furniture like side tables and coffee tables and those types of small furniture items. Now, am I saying that I would never use these in osteopenia? No, it's a scalar. So once they get to osteoporosis, I have to use all of these things. I may also use some additional estrogen modulators to treat this as well. But once you get into that class, I would say probably get them over to ortho. That class of medications is restricted in most medical treatment facilities. So ortho and endocrinology are usually the only people that have access. So if they're in the osteopenia and you're just ready to start treatment and making sure that they don't get to the osteoporosis, these are great things to start. I'm just saying that once they get to osteoporosis, these are mandatory. So our referral decisions in terms of what we're going to do, screening patients and treating. So don't wait until they are broken to send them to ortho. And that may involve a referral and maybe not to me. So it may be to endocrinology. It might be to behavioral health. It might be to ASAP. You can see there's lots of consults that could be in play there that don't have anything to do with their actual bones. Overuse syndromes. What are things that PA students have for 100? So the name really says it all. We're talking about a part of their body that gets abused. So repetitive trauma with an inflammatory and degenerative component. So they use something and they use something until it hurts. So that's usually what brings them in. So most of us do repetitive activities, but it doesn't always hurt. So if there's some change in that, so we did repetitive activity and now it hurts, that's what we're looking for. They should be able to localize that pain to the thing that is hurt. So if it is like a biceps tendonitis, they should be able to say biceps things to us. And we say, oh, that's a biceps thing. I can test that with my physical exam and say, yes, you've got a biceps thing. Same thing with like a patellar tendonitis. They should say that their pain is somewhere in their patellar tendon, and I can test that and say it's patellar tendonitis. And then if we get them to abuse said muscle, resist it during physical exam, that should increase their pain, make it worse. Or slam it with their reflex hammer. It's mean. So what do we do about overuse syndromes? So this is that part where it's at overuse right before it hits all of our tendinopathies. So it's getting bad, but it's not crazy stop all motion. So we may need to back them down on some activities, but doesn't mean complete cessation of activities. We should keep the rest, ice compression, elevation. The P here, just totally blanked out on it. I'm not going to think about it right now. Hold on. I'll come back to it. And slowly progress their activity. And we can use oral or topical, either NSAIDs or analgesics. So analgesics here means like icy hot, Bengay, Tiger Balm, those types of things. I text. I think it is. I'm going to go with Anders. I think it might be protection. Yes. See, we got two people weighed in. Because that's going to come into what we talk about with team management. So, see, you guys teed that off. I would have gotten there probably because I talk about why. So with this, that P is going to be protection with, for us, limited duty restrictions. So limb due or profile or whatever your service calls that, that's going to be our method to communicate to the employer or the regional, local leadership what they can and cannot do. So we have to make sure that they are not making it worse by continuing to do the things that are going to make it worse. On the outside, we work with nurse case managers to communicate with employers. So they may have like a union rep that can help with that, or a nurse case manager is our liaison to an outside employer that would say that we need them to stop certain activities or wear certain braces depending on the occupation. For instance, if it's a cashier and their overuse injury is about moving things in this way, then we may need them to not do cashier work and they may need to stock and put things up in a different plane of movement. So that's kind of how we communicate outside of that. So that's where that team approach comes in with the employer. So for military, that's kind of, we have our direct communication with the leadership. But outside of that, do keep in mind that there are other ways that we have to communicate with the employer. Sprains and strains. So sprains and strains. So a strain has to do with a muscle. They are graded grades 1 through 4. So a grade 1 strain involves less than 10% of that cross section of the muscle. A 2 involves 50% of that cross section. 3 is 50 to 100, but the fascia is intact. And last, the 4 is 100%, so complete disruption of the muscle and the fascia. So we talked yesterday about that fascial layer when we talked about fasciotomies in compartment syndrome. Then we have sprains, which are ligamentous in nature. So bone to bone, connects two bones, graded 1 to 3, just to make PA students' lives very interesting. So grade 1, sprain, see, even me, partial tears with no instability, no laxity. Once we get to 2, then we start to be able to measure that on physical exam. And then with a 3, that's complete disruption of that ligament. And we will be able to measure that with a physical exam finding. That is a great question for me to get to describe. Hold on, let me think of something outside of your body that has some kind of laxity. It's like a stretching of a rubber band. I think that's the best way to describe it. So yes, it has some give. I'm good with all of those. So if I pulled, hopefully on your ankle right now, it should not move at me. Whereas in someone who has a ligamentous tear, a complete one or a pretty significant, when I start to pull on it, it'll actually start stretching and come at me and disrupt. And so that would be laxity. Was that a clear enough? Just it's a tactile thing. So this whole COVID, I can't touch things. Rubber bandy. That's the best I can do with no tactile. Oh, did I finish that slide? Oh, okay. So they may have some history of trauma that would lead us down this path, something to disrupt that muscle or that ligament. And in terms of adverse outcomes of the disease, laxity can change the mechanics within that joint and put additional cartilage surfaces at risk. So kind of if you have shifting underneath, that would change the forces or the amount of grating that's occurring between those cartilage surfaces, could advance that or give you a secondary osteoarthritis picture for joint changes. And then obviously if a muscle is partly torn or mostly torn, you're not going to want to use it. And so you're going to atrophy adjacent sections, and that could coincide with some weakness. So our first guide is going to be, again, very similar to overuse injuries, point tenderness. So where does it hurt most, either when I mush on it or just at rest? Find that underlying structures, most likely to be one of the structures that were involved. Stability, kind of as we answered Anders's question, when you pull on it, is it a rock solid structure or is it like playing? Is it coming and stretching towards me? And then you may be able to even feel for a defect in some cases. So here, looking at this person probably has some kind of lateral epicondylitis going on. So looking at pain right there around the elbow joint. This person has this defect indicated here at the black arrow where we can actually see that something's different in that area. We could also palpate that area and we should be able to similarly feel that the Achilles tendon is not that nice structure. And we could compare it to the other side and see that. And then there's that laxity test that I was kind of trying to describe to Anders. So we stabilize the leg and we pull on the foot. We want it to be rock solid and not come towards our face, but laxity would be if that changes. We have some guidelines for imaging in terms of whether to get the imaging or not to get the imaging. Ottawa ankle rules, like the city in Canada. That's the to x-ray or not to x-ray. That is our question. And it has to do with where they have tenderness and their ability to bear weight immediately after their injury. Ability to bear weight, even if it's very uncomfortable afterwards, is kind of gives us a better feeling, gut feeling for what is going on. Inability to bear weight with tenderness at one of these 4 points is an indication to get an x-ray to evaluate further. So it's the most distal sections of the malleoli, either lateral or medial. So posterior and distal. And then the next section is where those associated tendons attach. So at the proximal fifth metatarsal or at the navicular. And so those are our tendinous attachments. So if there's some kind of concern there, or at the posterior and distal malleoli, those would be indications for additional studies. And then kind of what we're looking at with MRI is we're checking to see the integrity of those ligamentous section. So kind of what we're looking at here is this is a normal calcaneofibular ligament. So we can see it here at this positive arrow. If I put something on a test, it's going to actually have the rest of it. It happens to be out of plane here, which is confusing for you guys.